female-led panel, which is going to just be essentially discussing oral health in the African primary healthcare space. But to start us off, we just wanted to give you a brief context on who the Africa Forum for Primary Healthcare are and essentially what we do. So the Africa Forum for Primary Healthcare is essentially a diverse multidisciplinary primary healthcare workforce stakeholders from close to 40 countries in the region that advocate for primary healthcare and universal health coverage. And essentially our key activities are like what we have right now, a policy workshop, as well as continued professional development. We have a workshop this week on Thursday. Do tune in if you have time, around almost the same time. We also have a management course that is ongoing. We also have various clinical courses, and we do also have research that is currently ongoing, as well as a huge array of opportunities, which are all accessible and available on our website, AfroPHC.org. So when you have a chance, do have a look at our website and do tune in and plug in where you can. Without further ado then, I'd like to introduce a fantastic panel of oral health experts who will be taking us through today's discussion. We'll start off with an introduction. I'll introduce first all the speakers, and then from there, each of them will give us their presentations or their insights on essentially oral health, and also just to greet each one of us. So we'll start off with Dr. Anba Ganatra, who will be giving us the introductory presentation. Dr. Anba Ganatra is a public health specialist with a keen interest in primary healthcare, who currently works in Kiambu County in Kenya as a county dentist and the sub-county medical officer for health for Gatundu South. She also serves as the national deputy treasurer of the Kenya Medical Practitioners, Pharmacists and Dentists Union, as well as being a council member of the Kenya Dental Association. As a county dentist, she has planned and coordinated oral health programs at the community level and integrated oral health into existing programs such as the Beyond Zero program and the Transforming Health Systems programs by the World Bank. She most recently contributed to the curriculum design for an e-training course on oral health promotion, oral disease prevention and control for primary health care workers by the World Health Organization. So Dr. Ganatra probably could just say hello to those who have tuned in.
Hi everyone. Thank you so much, Dr. Marie-Claire, for that introduction.
All right, fantastic. All right, so we head over now to one of our panelists for today. We'll start off with Dr. Anusia Magan. She's a private general dentist and has been affiliated to the University of Witwatersrand since 1990. She's currently an honorary senior research fellow in the pediatrics department since completing a doctorate in 2018 on bone growth in South African children. She has mentored local and international PhD students in maternal and child health, health physiology, and oral epidemiology, and she has published in leading international journals and presented at local and international congresses. Her research interests are in skeletal and dental growth and maturity and oral health with a life course and interdisciplinary approach to well-being. Yes, fantastic. So yes, Dr. Magan, probably you could just say a quick hello to everyone.
Thank you very much for that introduction, Dr. Marie-Claire. Good afternoon, everybody, and I look forward to interacting with you later. Thank you.
All right, fantastic. And finally, last but certainly not least, sorry, just give me a moment. Last but not least is Prof. Sudeshni Naidu. She's an emeritus professor and specialist in dental public health at the University of the Western Cape. And she's also the director of the WHO Collaborating Center for Oral Health and has worked closely for nearly 3 decades with WHO in Geneva and Africa Consulting and assisting country members with the development and implementation of policy. She's involved in mainly with postgraduate education and training and has successfully mentored, supervised, and graduated nearly 60 masters and 15 doctoral students. Her research interests include how colonization and the social environment and political context influences oral health. And Professor Naidu has presented numerous scientific papers at international conferences and has been an invited keynote speaker nationally, internationally on several occasions. She spent many of the years on medical and dental professional board of the Health Professionals Council of South Africa and is a past president of the South African division of the IADR and the current president of the International Dental Ethics and Law Society on the preliminary committee of the inquiry at the Health Professionals Council of South Africa. So welcome, Professor Naidu. Sorry, Professor, you're mute.
Yes, I'm muted. Thank you. Hello, everyone. Good afternoon from very sunny, beautiful autumn Cape Town. Just to say I'm delighted to participate in this afternoon's workshop. So looking very much forward to interactions once we have finished our brief presentations. Thank you.
All right, fantastic. So yes, for everyone who's here, who is tech savvy, who loves tweeting, do tweet using the hashtag AfroPHC policy, and do tag us on @AfroPHC, our Twitter handle. Also do introduce yourself on the chat, and let's keep this conversation going. So I think without further ado, we will start off with Dr. Anbar's presentation, and then we can just take it from there.
Great. Thank you so much. Are you able to see my screen?
Yes, we are.
Okay, excellent. Right. So you've already done an introduction for me, and I wouldn't like to call myself an expert with the panelists that we have on board. I am just starting my journey in public health. And I always think that it's very important for me to highlight why I shifted from the clinical world to the primary healthcare world and what I have faced in the transition, because it sort of highlights what your expectations are and what actually happens when you get into the management arena. So I used to work in Gatundu South as a dentist for about 3 years, between 2013 and 2016. And I came to the realization that I was unable to meet the demand of the dental services that were required by the community. I started off as not very well-known dentist to somebody who even families from neighboring counties used to come to see to get treatment. And while I was working as a dentist, I realized that we need to focus on prevention. And so that is what motivated me to pursue my master's in public health. And I went and I came back and I got a job in the same district now as a primary healthcare manager. So, I mean, you can see the pictures. On the left is when I was working in the hospital, mainly in the clinical side. And on the right is now the jurisdiction that I manage. I manage about 9 healthcare facilities and community health units. And the assumption was that once I get to the other side, once I get into the primary health management side, I would be able to directly influence oral health care and bring about all the changes that I envisioned when I was working as a clinician. This is what we will be discussing today. And I think with the panelists on board, we'll be able to probably understand why it's not so easy to bring about integration of oral health care into primary healthcare and in general in the healthcare system, and what we will be doing, what we should do as a team. So since I was doing the introduction and I expected, like some of us may not be dentists on board, I wanted to define oral health, primary health care, and universal health care, and understand the burden of disease worldwide in Africa. And since I'm in Kenya, I thought I would focus on Kenya and why we need to integrate oral health care into primary health care. So what is the reason behind it, and why is it something that the WHO advocates, and what are the policy documents already in place for this? Because today we're having a policy workshop, but what exactly is in existence already, and what are the roadblocks? Why are we not able to achieve or implement those policies? And just have a discussion on that once we finish with my presentation. So most of us are aware that universal health coverage is one of the SDG goals, and it basically means every single citizen should have access to the health services they need where they live and work without facing financial hardship. And this is UHC is a goal for several countries, and it's also a main goal for Kenya. We were supposed to achieve. We are on the road to achieving UHC. It was a presidential aspiration by Uhuru Kenyatta, and probably will be for the next president. The UHC is a main agenda worldwide, and primary healthcare is seen to be the driver of UHC. And this was even talked about in 1978 when we had the Alma-Ata Declaration for Health for All. Primary healthcare at that point in time was the factor that would drive health for all. And even today, as we speak about UHC, primary healthcare is the driving force for UHC. And what primary healthcare is it's the first level of contact for individuals, the community, to the healthcare system. And I will describe Kenya's healthcare system because that's where I'm based. I would like to hear from others on board. But it's mainly the essential healthcare service available. And initially, in 1978, and when primary healthcare was being advocated for, the idea or the thought was that primary healthcare is cheap and doesn't need investment, and that's why we should push for it. But as we now analyze the situation, realize that yes, primary healthcare is not exactly cheap, but it's actually a better investment. Like, it's not that, oh, it doesn't require investment. It does require investment, but it has better long-term returns of health. So it's more economical in terms of investment. And finally, what is oral health? So oral health is defined as being free from the mouth and facial pain, oral diseases and disorders that limit an individual's capacity in biting, chewing, smiling, speaking, and psychosocial well-being. And this is a definition by WHO. And as we can see, without oral health, you're not healthy. And that is why we need to encompass oral health into general health. So I'll skip a few of these slides, but I was just trying to elaborate that oral health cannot be separated from general health. And that is why it has to be part of primary healthcare, because oral diseases actually affect the quality of life and affect, they can cause pain, they can cause social isolation, distress, and even death. So we need to stop isolating oral health from general health and making it a part of general health and a part of universal healthcare and primary healthcare. So that was just an introduction. Before we go into the Kenyan situation, I wanted to talk about the global burden of oral disease. And we've had the findings from the studies that were done in 2010, 2017, and 2019. And what is interesting in this is that untreated dental caries remains to be one of the most prevalent conditions worldwide. And it hasn't changed since the 1990s to current. It remains to be the most prevalent condition worldwide. And the prevalence tends to increase rather than decreasing. So we have seen diseases like HIV, the prevalence is dropping. After 2004, if we look at the prevalence of HIV worldwide, the prevalence is reducing. But for oral disorders, we remain to be the number one the most prevalent disease worldwide. And there seems to be nothing that we are doing to reduce this, and that's a cause for concern. And that's why we really need to focus on how are we going to reduce the prevalence of disease, and is primary healthcare the answer for this? And in Africa, since we're focusing on AfroPHC, the burden of oral diseases is about 400 million. And the conditions that we suffer from are dental caries, gum disease, oral cancers, normal. We also have oral manifestations of HIV. Fluorosis is also a major issue in some African countries. So these are things that we suffer from. And the sad thing is, most of these diseases are very preventable. Like other non-communicable diseases, oral diseases are the most common non-communicable disease, and they're largely preventable. And that is why primary healthcare comes in. When I look at the oral disease burden in Kenya, again, we have a very high burden of oral disease, and gum disease, for example, in adults is about 98%. That was from the first Kenya National Oral Health Survey. So that means almost every adult has gum disease in Kenya. Now, when we look at how oral health care is provided worldwide, access is very not consistent throughout the world, and also it's mostly in the private sector. So if we look at studies, they say that access varies in high-income countries versus low-income countries. Africa, now we have a majority of the middle and lower-income countries, so that's why we fall on the lower bracket. The access is only about 35% in low-income countries and up to 82% in high-income countries. And also this access now, it doesn't necessarily mean it's primary healthcare. It could just be curative. And if we look at the box here, which was meant to also describe universal health coverage, how do you achieve access? You achieve access by having the services available, the financial protection, and you also have other factors that allow you to make use of the services, such as geographic conditions, transport, the knowledge that you need to access dental services. So accessibility to dental services worldwide is very low. And again, it's inconsistent depending on the country. And the reason for this access issues, some of them are related to human resource. And if we compare Africa to the rest of the world, Africa has 3.3 dentists for 100,000 compared to the developed world, which has 32.8 dentists per 100,000 population. So we are facing a huge shortage of dentists. We are facing a huge shortage of oral healthcare providers. And that is again contributing to the lack of access to oral healthcare. And is it something that we can solve? Yes, by focusing on training, but also focusing on prevention of disease through primary care. The cost of oral healthcare is also very high, and majority of it is again in restorative dentistry or in the curative side of it. If we look, I didn't find data in Africa. I hope in future I can. But in Europe, oral healthcare costs 90 billion. This is more than even what cancer costs. And in the US, 101 billion was used in restorative dentistry. So you can see dentistry is a very expensive field, very, very expensive if we don't prevent the disease. So I'll skip this one. So based on all these factors that I've raised, all these issues that I've raised, the lack of access, the expense, the huge demand of dental service need, there is a need to integrate oral health into primary healthcare. And this has been suggested and advocated for by WHO. And it's not a new concept, basically. It's been there for some time. And in 2009, in the 7th Global Conference, the WHO pushed for the integration of dental care into primary healthcare. The African region was supposed to lead in this. Amongst all the other WHO regions, the African region is supposed to lead in this. And we need to evaluate where are we today, more than 10 years after that. And in 2016, the package of essential services for NCD interventions was introduced for primary healthcare. And we know that oral diseases share common risk factors with non-communicable diseases. So this was an easy area to integrate oral healthcare into, because NCD care requires prevention, healthy diet, counseling, early detection of disease, tobacco cessation, talks on not drinking alcohol, etc. So this was an easy area for oral health to be integrated. But is this package of essential services for NCD interventions even available? Aside from the oral health being integrated into it, was this package of essential services, has it been rolled out in our facilities? Has it been rolled out in primary healthcare facilities? And as a primary healthcare manager, I can say that it's still in progress. It's not yet been rolled out 100%. We only have a few facilities, for example, which I manage, that have NCD clinics. And again, they face their own challenges, which I will explain in the upcoming slide. And we have the common risk factor approach, which we're supposed to use in primary healthcare. So tobacco, alcohol, sugar are common risk factors that cause NCDs such as diabetes, cancer, and lung disease. So by addressing these risk factors, we would also be addressing oral diseases. So where are we at is the question where I was asked to address today. And I wanted to take it from my personal experience, and then I was also looking at, evidence that was there. So where are we at in terms of primary healthcare to begin with? Because if our primary healthcare is not even it's still fragmented, how can we achieve oral primary healthcare? So I think if I summarize where we are, this one statement caught my eye, that the African continent has 25% of global disease burden, and 3% of the world's health workers, and 1% of the world's health expenditure. So if I wanted to summarize where we are, I think this statement summarizes it, that we are very behind in terms of primary healthcare. So we have not been able to even integrate oral health into primary health. In case there's any questions, please ask. Yeah. So I wanted to just give my personal overview of primary healthcare in Kenya. And I work in the Tundu South, as I explained, and I lead 7 primary healthcare centers and dispensaries and 18 community health units. So I'm leading level 1, 2, and 3. So not level 4, 5, and 6. So we have 6 levels in Kenya, 6 levels of care. And level 1 is the primary entry, that is with the community health volunteers. So I've been lucky enough to experience primary health care in terms of being in direct contact with the people who offer these services and manage and also train them. And I can see from the 3 years of experience that I've had, oral health care was not integrated into primary health care. For example, even when we had training for community health volunteers, at that time, oral health care was not part of the training curriculum. And now going forward, it is. So this is the levels of care that we have. And in terms of the challenges and opportunities that we have, there are several challenges in integrating oral health into primary health. So the challenges first are that our primary health care is not in itself very structured. Before devolution, so Kenya went through devolution of health in around the year 2013. So before devolution, the primary healthcare, health promotion, health prevention were very well funded dockets. However, after devolution, when the county governments took over, health financing, health investments became dependent on governors' interests. So we have 47 counties, and each governor has their own interests, and most of them are going towards curative side, because that's what you can actually see the end game immediate. Like there's the immediate effect that you can see a hospital has been built, that people are getting x-rays or people are getting cured, but in investment in primary health, you can't see the outcomes immediately. So that's one of the challenges I have seen in being a manager after devolution. And some of the other challenges that exist in integrating oral health into primary health is the fact that dentists and oral healthcare practitioners in general, we are sort of isolated. So we have a silo effect. We don't generally study together with medics. We have our own separate schools. And then even once we graduate, we have our own work life. We come to the hospital, we see our patients, we go back. So this silo effect affects us long term. And I have seen that in my personal experience, because I left clinical dentistry for some time, I've been able to sort of see what else is happening outside the clinical world. So that has allowed some sort of integration. Like I've been able to integrate primary healthcare programs into programs that already exist, but that doesn't necessarily happen because not all managers or leaders are dentists, so they wouldn't be able to see what I see. We have lack of governance structures in place for the oral health sector, and that is true even in Kenya at this point in time. For example, we don't have chief county dentists in all 47 counties. We only have them in a few counties. Kiambu County was the first county to have a county dentist, and that is because I personally pushed for it to happen. Even though I wasn't given a formal recognition, I continued to work in that position. So there is lack of governance structures in place for the oral health sector. And then when we have oral health policy, so we have now, for example, in Kenya, there was one that was drafted that expired, I think, in 2012. After that, now we're currently working on 2021, 2030 oral health policy. It is in place, the policies may be in place, but what is the commitment to put the policies into action? And I want to hear the discussion today after the other panelists present, that health in Africa, I think, is mostly a political agenda. And so some of us draft policies without taking into consideration the political, what is the political interest? So that is an issue that we have faced. And oral health as such, it's not only in Africa, worldwide has faced neglect, international neglect. Yes, so I think I've mentioned that we have a political neglect internationally. And even in terms of the primary healthcare structure in Kenya at the moment, there is a lack of supportive supervision. There's just a general lack of investment in primary healthcare. So how can we achieve integration if the primary healthcare itself lacks the investment that it needs? So of course, with every challenge, there's opportunities. And I can say that this platform is also an opportunity. I can see that there's a lot of interest amongst non-dentists, non-oral healthcare workers to involve us, and also more dentists are getting involved in primary health, public health. That's a good opportunity for us. We have policies that are in place, and now we need to sit and see the way forward. And yeah, we need to, as an African continent, lead in the integration of oral health into primary healthcare, as was envisioned. In terms of financing, again, primary health care itself is underfinanced. So from my personal experience, as the Sub-County Medical Officer of Health, we were supposed to be funded by the hospital, and we are meant to actually identify diseases, priority setting, set up priorities of the sub-county. So in my area, which disease is the most common? Is it NCDs? Is it diabetes? Is it oral disease? And then we're supposed to plan programs for the prevention of these diseases. However, after devolution, that funding stopped completely. And even though now we may have funding set aside specifically for health, it is still focused towards curative. So it's still a push and pull, and we really need to continue to push for primary healthcare financing. And once we achieve that, we need to ensure that oral health is part of that. So as an example, I'll say oral health sector receives negligible budget in the year 2015 to 2016, which was the last time oral health sector in the national area received a budget allocation, was only 0.036%. So that's very negligible. Another thing that we face in the primary healthcare, which is, I would say sometimes I face a limitation, is primary healthcare programs are donor funded, and donors have their particular interest. So even if we can integrate oral health into those programs, there's no funding. It becomes difficult to integrate them without, actually having, we cannot show that we integrated oral health into these donor-dependent programs, because the donors come with their own agenda that, okay, we only want to focus on HIV. So if there's a program happening for HIV and you do integrate oral health, how do you account for it? So you may do it behind the scenes, but it's really not accounted for. So you can't monitor it, you can't evaluate it. So those are some of the problems we face in primary healthcare. And donor-dependent programs, in as much as, yes, they support and push an agenda, they sometimes fragment our health systems further. And the biggest problem that we face in primary healthcare, in health in Africa, is the shortage of healthcare workers in general, and oral healthcare workers is a big problem. In Kenya, we only have less than 1,000 dentists for a population of 50 million. I saw that South Africa has 6,000 dentists for the same, about 59 million. So, I mean, that's impressive because we only have 1,000. But we basically have a general shortage in the healthcare sector. And the issue is the primary healthcare facilities, those who work in those facilities are overworked. So they are meant to also manage the facilities. They're meant to do reports. Most of them are nurses, and they do the work of a clinician. They are meant to now ensure that they run NCD clinics, HIV clinics, malaria, vaccination. So how much can one person do? And now we want to also integrate oral health into this. So the major issue that we have, the overall issue, is that we have a shortage, and we need to tackle this shortage so that we can finally integrate oral health into primary healthcare. And we have a general lack of data on oral health in Africa. We don't even have data to monitor and evaluate the programs that are already in place. I try to look for them. And we don't integrate our oral health indicators into our health information systems. So for example, we have the health information system in Kenya. So oral health indicators are not integrated. Even the community health volunteers who work in the field, the data that they collect, we have just improvised and added oral health into it, but it's not a national, it's not done nationally. And those are things that we need to work on so that we can actually have oral health as an indicator nationally, and finally be able to monitor and evaluate any of the programs that we do. So I think that's it from me. I would say way forward, we have the policy documents. We have a lot of guidance from WHO on what to do. So the way forward is now to implement, and we need to see what is it that is the roadblock to implementation. We need to integrate oral health programs into existing successful programs, and we need to make oral health a security issue like COVID-19 was. I mean, it's been an issue since very long, and if we were able to invest so much in COVID-19, we should be able to do the same for oral health. We need to commit to primary healthcare for universal healthcare. As much as we want to commit to insurance, having everyone be insured. Yes, insurance is one of the pillars of universal healthcare, but also the service provision is very important. So primary healthcare will allow us to achieve that. And finally, we need to understand the political influences that lead to policy implementation as oral healthcare workers, so that we are sort of on the table, going forward. Thank you. I think that's it from me.
All right, fantastic. Thank you so much, Dr. Anwar, for that presentation and for giving us your insights from the Kenyan perspective. I think we now head over down south to now Dr. Magan next, who will now give us her perspectives on the value and role of dental practitioners in the primary healthcare team and practice. For about 10 minutes, and then finally we have our last presentation, and then a small panel discussion and Q&A before we go to group discussion.
Thank you, everybody. Are you able to hear me? And can you see my slides?
Yes, we can hear you. We can see your slides.
Thank you.
Yes, we can hear you and see you.
Thank you. Thank you. So whilst this may be the title of my presentation, everybody, today I'm simply going to talk about why mouths matter. The mouth can be regarded as a window to general health, as you've just heard from Dr. Ganatra. And that is really because an estimated 100 systemic conditions and more than 500 medications have oral manifestations. Now, for most of my career as a dentist, I can honestly say that whilst treating patients, aside from taking a medical history, I did not look beyond the oral cavity. In 2013, I started my doctorate in bone growth in children in the pediatrics department at Wits University. And that is when my perspective started to change. In my interactions with researchers in nutrition, non-communicable diseases, and public health, I realized that not only did they not consider oral health issues in their thinking about overall health, but that they showed a limited understanding of the connection between the mouth and the rest of the body. My aim today is therefore to highlight why oral health is inextricably linked to general health, and why there needs to be a multidisciplinary approach to health that includes oral health and oral health care workers, particularly at the primary healthcare level. So while we all aspire to have the perfect dentition like Halle Berry, the reality of the situation is that close to half of the world's population are affected by an oral disability. The two most common oral diseases are caries, or tooth decay, and periodontal disease, which affects the supporting tissues of the teeth. That is the gums and the bone that surround the teeth. Now, caries can occur at any age, but periodontal disease is predominantly, but not exclusively, an adult disease. So these two oral conditions will form the basis of my presentation today. Now, Dr. Ganatra has touched on the burden of oral diseases, but just to recap, that of all the 300 plus conditions in the 2015 Global Burden of Diseases study, oral conditions affected 3.5 billion people. Untreated caries of a permanent dentition with a prevalence of 34.1% ranked #1 as the most commonly occurring disease, whilst untreated caries in the primary dentition and periodontal disease, both with prevalences of just over 7%, were still in the top 10. So this is a global health crisis, and it is for this reason that dental care needs to be included as part of universal health coverage. We've also learned about the prevalence of caries in Kenya from Dr. Ganatra, but allow me to discuss the situation in South Africa, which is where I am based. In South Africa, caries prevalence remains persistently high. We haven't had a national oral health survey since 2002, but data collected at that time showed that nationally the caries prevalence was about 60%, but that 75.2% of these children had unmet dental treatment needs. Recent studies in the Western Cape and Johannesburg show that 20 years later, not much has changed. In the Western Cape, in children younger than 6 years from low socioeconomic backgrounds, close to 72% had caries experience, but 67.5% of this went untreated. Similarly, in children recruited from 10 preschools in Johannesburg, 44% had caries experience, but a staggering 97% of this had gone untreated. I'd like to briefly discuss the etiology of caries and periodontal disease. So caries is a non-communicable disease with a multifactorial etiology. And this diagram shows that for caries to occur, there has to be an interaction between diet in the form of fermentable carbohydrates, cariogenic bacteria on a tooth surface over time. And any change in the oral environment, be it due to changes in the salivary composition or flow rate, a compromised immune system, or poor oral hygiene, disrupts the bacterial ecosystem and promotes caries formation. Fluoride has a protective effect and reduces caries risk. And as an aside and hot off the press is that the World Health Organization has just recently included fluoride in its model list of essential medicines. And this is a significant breakthrough for dental public health. Anyway, all of this occurs within the ambit of socioeconomic factors. Periodontal disease, on the other hand, is an infectious inflammatory disease, and it occurs in the presence of pathogenic bacteria a susceptible host, and risk factors such as poor oral hygiene, smoking, and excessive alcohol consumption. Now, we've also heard about the shared risk factors, and I'd just like to briefly discuss it a little bit more. Caries and periodontal disease share modifiable risk factors with non-communicable diseases. NCDs are broadly classified as cardiovascular and chronic respiratory diseases, diabetes, and cancer. And some of these modifiable risk factors include a diet with high sugars content, tobacco use, and excessive alcohol consumption. The oral diseases also share pathophysiological pathways with NCDs, and these include inflammation, altered host tissue responses, altered host responses rather than altered tissue homeostasis. In 2019, the World Health Organization considered NCDs as the second greatest threat to global health. And also note that weak primary healthcare systems featured on the list. Now in South Africa, we're seeing an increase in prevalence of NCDs amongst adults due to a rise in the risk factors. Adding to the NCD burden has been a nutritional transition. And this has been due mainly to a shift from traditional diets to more energy-dense fast foods. For example, the kota was the most popular choice of fast food among 17-year-olds in the birth to 20 cohort in Soweto. And this was due to its affordability and its filling ability. In the same cohort, more than 2/3 of the participants consumed fast foods and sugar-sweetened beverages at least 3 times a week. So this high intake of sugars is not only detrimental to oral health, but also contributes to the development of chronic conditions such as obesity, and therefore the risk for NCDs. Overweight and obesity on the rise in South Africa. In 2013, 26% of adolescent girls were overweight or obese, while a recent study reported an alarming 43% prevalence of overweight or obesity amongst adolescent girls in rural Limpopo province. Coexisting with these high rates of overweight and obesity is a high prevalence of undernutrition. And we therefore have a situation of a double burden of malnutrition. Undernutrition causes stunting, which is a significantly low height for age Z score compared to the WHO reference growth curves. The prevalence of stunting is remarkably high across the African continent, ranging from just over 20% in South Africa to extremely high levels of more than 50% in countries like Burundi and Niger. This diagram shows the pathways through which poor nutrition affects the risk for stunting and NCD development through the life course. It also shows how this is transmitted to the next generation. So undernutrition in infancy and childhood affects linear growth and causes stunting. When these stunted children consume energy-dense foods, they are at greater risk for becoming overweight or obese and developing NCDs. Also, females who are stunted in childhood are more likely to bear stunted offspring. And so we end up with a vicious cycle of poverty and impaired human capital, which is driven by nutrition. And this is extremely difficult to break out of. With this in mind, I'd like to look at the scenario of how poor maternal oral health during pregnancy can impact the health and well-being of both mother and child. Now, during pregnancy, women may experience changes in their salivary composition and flow rate, and this leads to a more cariogenic environment. Hormonal fluctuations in pregnancy are associated with inflammatory mediators, and these affect vascular permeability and connective tissue turnover. Collectively, these factors, coupled with poor oral hygiene, increase the risk for caries and periodontal disease. This is a photograph of a 23-year-old woman with severe periodontal disease. Her poor periodontal condition puts her at risk for becoming diabetic, since studies have shown that there's a true bidirectional relationship between these two conditions. She's also at risk for developing cardiac and cerebrovascular disease, which are both strongly associated with periodontal disease. Pregnancy, in her case, presents a risk to the fetus. And there's a growing body of evidence for the association between periodontal disease and adverse birth outcomes, such as preterm birth, being small for gestational age, or having a low birth weight. Now, preterm birth is a leading cause of neonatal morbidity and mortality. Worldwide, an estimated 13 million infants are born preterm every year. More than 15% of these births occur in developing countries, and 9 of the 11 countries reported are in sub-Saharan Africa. I'd like to briefly mention 2 studies in relation to periodontal disease and birth outcomes. The first is a very recent South African study of 442 pregnant women, 74% of whom had periodontal disease. Just over 75% of the mothers with severe periodontal disease delivered infants with low birth weight. The study also found that an increase in the severity of periodontal disease was associated with a decrease in mean gestational age. The question that then arises is, does treatment of maternal periodontal disease improve birth outcomes? Well, a systematic review and meta-analysis of 20 randomized controlled trials found that maternal periodontal therapy did in fact reduce the risk for preterm birth. And in addition, there was a significant increase in birth weight. So given these outcomes, surely we should be looking more closely at the oral health of pregnant women. Let's move on to the child. This is a slide of a 5-year-old with early childhood caries, and it clearly highlights how and what a mother feeds her child impacts her child's oral health. And yes, breast is best, but it is the frequency and duration of breastfeeding that can have an adverse effect on a child's teeth. Prolonged breastfeeding beyond the age of 2 years or inappropriate feeding in infancy and early childhood results in the development of severe caries. This affects the child's ability to eat and leads to undernutrition. Early childhood caries usually results in premature loss of teeth, and this alters the growth pattern of the jaw bones, resulting in a malocclusion. As a result of the malocclusion, airway and breathing are compromised, and the disordered breathing that ensues is associated with several adverse consequences beyond the mouth. Of interest, though, is that the disordered breathing is also associated with a decrease in growth hormone secretion, which we know is essential for linear growth. So these pathways are complex and they definitely need further investigation. But what they clearly highlight is that oral health may affect general health in more ways than we realized. Let's look further at the relationship between early childhood caries, malnutrition, and linear growth. So this relationship was investigated in a study in rural Ecuador. Ecuador is a middle-income country, and it has epidemiological profiles of caries, malnutrition and stunting very similar to those of South Africa. The cohort included just over 1,500 children, aged between 6 months and 6 years. Preventative intervention was carried out 3 times a year for 2 years. And this intervention included nutrition and oral health education for children and families, toothbrushes and fluoride toothpaste for all family members, child dental screening and dental treatment as needed. So at baseline, more than 50% of the participants consumed junk daily. And caries prevalence amongst the 1-year-old group was close to 54%. After 2 years of intervention, junk food consumption had halved, and caries prevalence in the group that had entered the study at the age of 1 year was reduced by 1/3. So the benefit of the intervention is actually quite obvious. But what is even more interesting is that in a subsample of 66 children younger than 4 years, after the 2 years of intervention, there was a significant improvement in the height for HZ scores, which translated to a 39.5% reduction in stunting. Overall, this study highlights that simple interventions that improve oral health ultimately have a positive impact on general health. Many of these interventions can easily be performed by oral hygienists and primary healthcare workers. Why then do we have such a burden of disease? And I certainly cannot address this in any depth, but I will briefly touch on 1 or 2 aspects. There is no doubt that one of the main issues is the shortage of oral healthcare workers in the public sector. In 2018, more than 90% of South African dentists were working in the private sector, providing services to a mere 16% of the population. So whilst our number of dentists per capita sound a lot better than Kenya, Dr. Ganatra, there's certainly a gross maldistribution. The under-resourced public oral health facilities are mostly serviced by dentists and dental therapists, when in fact there's a greater need for oral hygienists whose skills are more suited to the primary care setting. And recently, the South African government approved independent private practice for oral hygienists. And the disadvantage of this is that it is a further loss to an already strained public sector. Another challenge that we face is the lack of empirical studies to drive policy. So here are some of my recommendations from a research perspective. We need to adopt a common risk factor approach to address the determinants of oral diseases and NCDs. Studies on oral disease prevention and management need broader conceptual frameworks, which include NCD-related biological, social, and psychological factors. And lastly, there is a great need for cohort and intervention studies. And we need this to establish the intergenerational effects of maternal factors on child, oral, and general health. To conclude, pregnant women and children are a vulnerable population. Improving maternal and child health is fundamental to uplifting communities. So in the context of my presentation, how we approach this as a multidisciplinary team, which includes oral healthcare workers, needs to be addressed urgently. I thank you for your attention.
Thank you. Thank you so much, Dr. Magan. I think that is quite a holistic view of how what seems to be a simple oral health issue can be bigger than what we see. So I think finally we have Professor Naidu to give us her insights in her presentation. Before now we head over into the discussion session. So over to you, Professor Naidu. Do let me know if you'd like me to share the screen.
I'm going to try and do it myself, but let's see if I can manage. So I think once again, just to say I'm delighted to be able to present at this important timeous meeting, and would like to thank Marie-Claire and the rest of the organizers for inviting me to participate. And I trust that my presentation now is going to tie in very nicely with the excellent background we have got from my two colleagues earlier on, which has set the scene very nicely for us. So let me try and see now, sharing my screen there. And do I say from the beginning? I think one back. Can you see everything now? Is it clear?
Yes,
Okay.
yes, it is.
Yes, it's very clear.
Okay, I might just want to stop my video if you don't mind, just so that it's all clear. As long as you can hear me, that would be great. Is that okay?
That's perfectly fine, Professor
Okay.
Naidu.
Right, so I'm going to try and follow up now. And as you might have seen, my talk was entitled talk about models for possible integration of oral health services into the primary healthcare settings. And that's a challenge for us, as you heard from two experiences, both from someone who's working in the public health dental sector and somebody private and university background. And we know that in most countries around the world, the medical and dental professions operate in parallel with non-intersecting education, finance, and delivery systems. Both provide health promotion, disease prevention, and routine services and emergency care, but dentists focus on the oral cavity, and the primary healthcare providers are often the first to connect with coordinating, continuing care for the rest of the body. The lack of infrastructure, technology and personnel to connect these separate systems means that the public have to navigate across this dental and medical divide on their own, often without the necessary health literacy skills and resources. And research has shown that inequities in access to essential health services and poor health is attributed to these independently functioning medical dental care health systems and are missed opportunities for us to provide these services. Government, philanthropic, and professional organizations, bolstered by research, by case study findings, are now slowly beginning to add support for integration of oral health into primary health care. And as we heard from our first speaker, primary health care is often the very first level of contact of individuals, families, and communities that they make with health systems, bringing healthcare as close as possible to where people live and work. And it often includes a large range of services such as oral health care, and it often encompasses a variety of healthcare providers across private, public, and non-governmental sectors. The integration of oral health into primary care has been implemented in fragmented ways in some healthcare systems, trying to reduce the burden of oral disease and to improve access to oral health care, especially for those disadvantaged and in underserved communities. And this approach essentially will empower health promotion, oral disease prevention and will favor health equity by including things like risk assessment, which we heard is so critical, oral health evaluation, preventive interventions, etc. But interprofessional collaboration is critical. It is a better way to provide whole person healthcare, and policymakers are leading this charge towards integration. And we've heard then why integration is important. And just to quickly reiterate, we know that the common risk factors and strong biological relationships between what occurs in the mouth and the rest of the body indicates a need to incorporate oral health care into general patient care. Furthermore, integration can reduce the overall cost of healthcare. Screening for chronic diseases like hypertension, diabetes, for example, in dental surgeries in the United States, was found to decrease healthcare costs by over $100 million annually. And a modeling analysis estimated that over a 10-year period, savings of over $60 billion in healthcare costs could be accrued due to fewer hospitalization and emergency department visits. We heard too about the maldistribution of dental and primary healthcare professionals, and this results in access to care issues that do not always coincide, and many vulnerable population groups with untreated disease often obtain medical care, but not oral health care. And patients with dental problems are increasingly presenting now in hospital emergency departments. And we know that improved access to oral health care and the cross-training of primary healthcare workers to treat dental emergencies can go a long way to prevent patients from receiving expensive care that may also lead to other healthcare crises. We heard about the importance of oral health and general health, and that how it's intimately related to general health, the common risk factors, and that bi-directional relationship begs for integration of oral health care into primary health care, and that holds the key to affordable and accessible health care, as oral health is often neglected in many countries. And I will be talking then for the rest of the lecture on various ways we can use to integrate oral health into primary health care, such as things like interprofessional education, collaborative practices, referral processes, but we would need to increase financial resources, our healthcare workforce, and certainly government support and buy-in from them is critical to ensure sustainability of this. So despite the growing attention towards an integrated oral health and primary healthcare system, there is a paucity of literature on oral health integration models, and it remains unclear how and in what contexts this approach is being applied and how successful it is in practice. So in this short presentation, I'm hoping I am going to identify and describe some models and policies for integration of oral health into primary health care, and going to try and discuss issues of conceptual and applied models related that are currently in place, together with policies that exist trying to integrate oral health into primary health care, and then to talk a little bit about the extent to which integration of oral health care into primary health care improves health outcomes. I want to add, though, that unfortunately, most of these theoretical and applied models that I am going to talk about are mainly from 6 key countries that have developed conceptual frameworks and policies and strategic plans in this area. So I'm going to start off with 2 conceptual frameworks that have been developed in the United States. And the first one is an integration of oral health and primary health care in practice. And this initiative essentially covered 5 domains of risk assessment, oral health evaluation, etc. And secondly, the oral health delivery framework, that was something that was developed in partnership with a variety of healthcare workers, primary healthcare workers, dental clinicians, and interestingly, they also developed this with the end users and patients. And this framework, their activities include things like screening for oral diseases, the identification of high-risk populations, fluoride varnish to pediatric patients, patient education and dietary counseling, oral hygiene training, all things that have been discussed in the earlier 2 presentations that we have heard. So when we move on to policies and strategic plans, these are rooted in the universal acceptance of the primary healthcare approach that was established by the Alma Ata Declaration way back in 1978. And then we know, while the first strategic plan was published in 1982, the more recent 2007 World Health Assembly called for a strategic planning entitled Oral Health Action Plan for the Promotion of Integrated Disease Prevention. And at this meeting, 193 of the WHO member countries agreed on the implementation of the WHO Global Oral Health Program. And in the last decade, all of these countries have set general policies for oral health action using these guidelines together with the concept of the common risk factor approach. However, on account of the worldwide variation in oral health care organizational systems, the specific policies on oral health integrated care differs not only between countries, but also within countries at national and provincial levels. In most of these countries, policies are focused on care coordination plans rather than to fully integrate oral health strategies into general health strategies. However, in some countries, such as Canada, Australia, and the US, policies for integrated care have put emphasis on specific population groups, such as early childhood, children and adults with special needs, elders, rural communities, as well as Aboriginal and Indigenous populations. And I shall give you now some country examples where there has been attempts at integration. And I will start off first with Brazil, that has been a pioneering developing country that has implemented different government, federal, and municipal policies to completely integrate oral health professionals into multidisciplinary primary care teams. And in 2004, it launched a national policy for oral health that linked specific strategic plans to other public healthcare policies, including the reorganization of primary and specialized care, fluoridation of the water supply, and oral health surveillance, some of the critical issues that are necessary that our first speaker described this afternoon. And these policies were successful in the implementation of a sustainable integrated oral healthcare network that optimized oral healthcare services to all its citizens, despite some persistent challenges such as cost and resistance from the private sector. So moving on to the industrialized countries, various strategies have been tailored to foster those WHO principles I spoke about. And in 2011, for example, 42 United States adopted policies under the Medicaid, Medicare grouping to encourage general physicians, pediatricians, and other primary healthcare providers to provide some basic oral health care to their patient populations. In Europe, collaboration of various dental groupings implemented a platform to support oral health policies through the development of cross-sectoral approaches and the collaboration of other health and social care professionals into oral health care. In the UK, following the Health and Social Care Act in 2012, dental professionals were permitted to collaborate with a variety of other stakeholders and local authority public health teams to achieve a continuity of oral health care across both the public and the private sectors. In many instances, programs designed to integrate oral health into primary health care have been in the public sector and in partnership with various private and public care organizations. These programs used a variety of strategies to empower integrated care, including things like the building of interdisciplinary networks, the training of non-dental care providers, oral health champion modeling, and enabling oral health care linkages with care coordinated processes, including the use of e-health technologies. But in many countries, a high-risk strategy approach has been used to create integrated oral health care programs. Accordingly, these integrated care has focused on groups with the highest risk factor levels for oral diseases, like child and maternal age groups, the elderly, and persons with disabilities, as well as rural and remote communities. In addition, there have been programs that have been initiated by dental schools in collaboration with community-based organizations. And for example, there are many examples of this, an example being the infant oral health care program that was developed by the University of California, where they increased family-centered access to care and the utilization of dental services, the adolescent maternity program, that provided oral health educational guidelines within prenatal services. We had an example with Health Canada in collaboration with the University of Toronto, developing what they call the Sue Lookout Project, where dental clinics and facilities were integrated into nursing stations in remote First Nation communities. And here they were offered fly-in dentists and certified dental assistants and hygienists who helped them with their oral health needs. And in Australia, the Centre for Rural and Remote Oral Health used networked hub and spoke models of care where dental clinics were integrated into rural and remote Aboriginal medical centres. So these are all examples from all over the world where we can emulate integration into medical and other healthcare settings. I don't need to really talk much about how beneficial this kind of and how important it is, because oral health involves a broad team of professionals. Although supportive environments can potentially improve oral health outcomes, there have not been enough studies to determine the extent to which outcomes are improved and if the needs of vulnerable and disadvantaged populations are, in fact, being fully addressed. But positive outcomes include enhanced interprofessional collaboration, satisfaction of non-dental primary care providers with oral health care training, and increased performance of non-dental care providers. Some of the more objective outcomes include an increase in the number of trained non-dental healthcare providers, the number of dental visits and screening, preventive acts, referrals, as well as a decrease in percentage of patients' dental treatment non-attendance. In the Netherlands, Gerritsen compared dental care that involved 2 nursing homes with about 35,000 inhabitants. And in the center providing integrated care, although the cost of dental care itself increased by about 86%, the average dental care time for patients was 20 times greater and translated into a reduction of more than 40% of dental treatment needs among the senior citizens. Oral health involves a broad team of professionals. In this regard, we need to help patients and communities to visualize the different places where oral health care services are provided. For example, in primary care facilities, in mobile care units, etc. And in doing so, it will help more public thinking beyond the problematic belief that dentists are the system, and the idea that oral health care systems only comprise of dentists and dental hygienists. One of the main problems with this way of thinking is that our other important allies and actors in the system, such as primary health care providers, school nurses, and pediatricians, are invisible in this equation. And I'm going to briefly go through 4 case studies where there are examples of medical and dental collaborations. And in the first one, we find that a statewide program was among the first where a type of integration appeared in the United States, merging oral health with dental health. And in this program, trained primary healthcare physicians and other medical care providers were reimbursed for medical visits in which primary oral health care, like screenings, risk assessment, dental referrals, the application of fluoride varnish, was done and provided to young children. And the goals of that program were and continue to be an increase of primary oral health services for low-income children, to reduce the prevalence of early childhood caries, and ultimately to increase healthcare delivery's capacity to serve the oral health of young children. And this particular integration model suggested that it was sustainable, it was effective in reducing inequities in access, particularly with oral health care and for those with poor oral health. The second case was related to us embedding dental personnel into areas where people are receiving medical services. And in this example, we had oral hygienists providing preventive services with indirect supervision from dentists in an obstetrics gynecological clinical setting. There were benefits to pregnant women's oral health. They addressed oral infections that could, as we heard from Ansia Megan, that the potential for poor birth outcomes. And these kinds of interactions can go a long way to improve the oral health of future babies and any further siblings of these families. The other examples that were given were oral hygienists who were co-located in primary healthcare clinics and other settings with underserved populations. In other settings, dental assistants were trained to provide screening, health education, and offer fluoride varnish. There's with the increasing problem of dental visits to the emergency departments in hospitals, some communities have further explored the possibility of embedding oral healthcare workers in emergency departments to specifically handle dental symptoms. Another example was where preventive health services are carried out by dentists, where dentists provide health services, looking at it the other way around, where they can screen for the non-communicable diseases like high blood pressure and high blood glucose levels. So in this example, a grouping called Health Partners, they began their integration with the dentists, where they got them involved with into a multidisciplinary team where the doctors looked at caries, oral cancer, prophylaxis, etc., where then the dentists were involved with measuring blood pressure and blood glucose levels of patients and then referring them to the relevant medical setting. And here there was this positive impact among the enrolled patient populations, where the dentists were seen to assume a more proactive role in referring patients for a variety of non-communicable diseases. On account of time, I'm going to not talk so much about this final one, where there was integration with the diabetes program, but positive impacts were found with this case that led to medical and oral healthcare workers together altering their case management for patients with diabetes. So as we can see, there is an effective need for policies on interdisciplinary approaches to improve the oral health, particularly of disadvantaged populations. And we know that primary healthcare is not a new concept. But we know too that theoretical and conceptual models in oral healthcare are not very well developed when we compare it to our medical fraternity, nor are the various taxonomies of integrated care well differentiated or applied in our field of oral health. But in this regard, the WHO has provided leadership, providing an overview of taxonomies and certain models of integrated care that are used to analyze the level and mechanisms of integration with oral health and medical care. But the breadth and level of and intensity of integration varies from integration of healthcare models to specific groups to full integration. But these taxonomies have been used in the development and implementation of of other models, such as integrated care models, group and disease-specific models, as well as population-based models. And although in countries such as Canada, for example, integrated care delivery models like PRISMA, for example, were developed more than a decade ago, unfortunately, oral health has not been included due to the fact that dental care is covered mostly in the private sector. But I have spoken about Brazil, where healthcare policymakers have implemented policies that favor the population-based models, such as something called Smiling Brazil, where it has been incorporated very well into their national health policies. And these models do recognize that oral health is linked to environmental and societal factors and needs to be improved within supportive environments using culturally appropriate strategies. And the main limitation we find with these population-based models is their considerable cost, which makes implementation difficult or unlikely. But in Brazil, despite the effectiveness of their programs in terms of oral health care and access, implementation continues to encounter difficulties more than a decade after its adoption. On the other hand, the choice of integrated oral health care modules in different countries depends on the clinical service organizations, the vision and values within a community, and governance systems and policies. So I hope that this presentation has highlighted the importance of policies in promoting the integration of oral health care into primary health care, the integration and implementation into interdisciplinary public health care programs to improve the oral health care, particularly of our rural and disadvantaged population groups. We need to enhance oral health integrated care by building interdisciplinary networks, training non-dental healthcare providers, oral healthcare champions, by enabling care linkages and coordinated processes, as well as tapping into e-health technologies. In addition, there is a need for more scientific, evidence-based, rigorous evaluation research to provide data on cost effectiveness and sustained outcomes of oral health integrated models. And this is particularly important, as we heard, in Africa, where there's a dearth of surveillance and information available. So with that, I'm going to say thank you so much for your attention, and let's see what the rest of this policy workshop is going to bring with interaction from the participants.
All right, fantastic. Thank you so much, Professor Naidu. I think now that's quite an informative presentation that sort of brings home what global commitments they are regarding oral health. So I think now for the next few minutes, we will now proceed to an overall group discussion, given our current numbers in this policy workshop. So I think for starters, I will reiterate that if you have any questions, I think we could start off with a round of questions on what has been presented. Just brief questions. We'll probably take like 3 questions, 1 per presenter. And then now we can head over to a panel discussion. And then if there are any questions that come up from the panel discussion, we can take it from there. So if there are any questions, you can post on the chat or you can raise your hand and I will facilitate as required. I have one question that was asked by Kumba, which was, what is the role of the dental therapist? I think I will address this question first to Professor Naidu, and then Dr. Magan and Dr. Anba can give their insights accordingly. And also, please don't forget to keep tweeting at AfroPHC on Twitter, hashtag AfroPHC policy. So over to you, Professor Naidu.
Thank you. Yes, very important, the role of dental therapists. We started training dental therapists many, many years ago in South Africa, with view to then, once they had trained and qualified, moving into the public sector and to really provide access to participations in the rural settings. And unfortunately, that scenario did not work out as was planned. And we ended up with a situation where we were training dental therapists who were unable to find positions that were initially earmarked for them to service those particular rural areas, and which meant then that many of them had to look at options for going into private practice. So unfortunately, we still seem to be in that kind of scenario in South Africa, where we have a cohort and still continue to educate and train dental therapists, but sadly, many of them unable to find positions and jobs in the settings that they are most suited to be working in. But certainly as a cadre of oral healthcare workers for basic care and training and education, there is an important role for them to play in the dental setting, and particularly now, as we discussed, in the primary healthcare setting. It would be interesting to hear the situation in the rest of Africa, and perhaps what Dr. Ganatra has to say with regards to the use and training of dental therapists in Kenya, for example.
Yeah, thank you so much for that. Yeah, in Kenya, Professor Naidu, we have community oral health officers, and I was reading about the dental hygienists, and the role of community oral health officers in Kenya was meant to be primary oral health care. However, we face the same issue that you have in South Africa, where community oral health officers are trained and they are not recruited in the public sector. And even if they are, they tend to work in the higher level hospitals. So they end up providing curative care. So the public health sector the primary healthcare sector still has a severe shortage. Yeah. It's the same situation. And actually, a few weeks ago, we had to discuss the scope of practice of community oral health workers, because they end up doing more of curative work, which they were not trained to do while they're in school. So those are some of the challenges we face in Kenya as well. Yeah.
Perhaps I could ask the question. I think it might be to not just the panelists, but to the audience. Is there a clear idea of other countries and the way in which they structure the various sort of task shifting cadres? So below a dentist, what are the other cadres, and is there some sort of uniformity about the way in which they are functioning? An example is in primary care, we have a doctor, then there's a primary healthcare nurse who has a very much more limited range of work. Sometimes clinical officers also function with slightly different ranges. is that kind of layering of task shifting, task sharing in oral health clearer? Maybe with the South African sort of examples would be useful to clarify. And then if the others from other parts of the African continent could say whether they've got equivalents. Do you mind sharing that, perhaps Dr. Magan or Prof. Naidu?
I think with us, it's pretty straightforward in the sense that we have the dentist at the most professional, for want of a better word, of the oral healthcare grouping, who's able to do supposedly curative and preventive and all sorts of other surgical treatments. Then we move to a dental therapist who has a limited range of curative and restorative work that they can do.
And usually trained for how long? Maybe that'll help as well.
They are trained, for 3 years.
As opposed to a dentist for 6 years.
As opposed to dentist, which is 5 years.
5 years, okay.
And then the dental therapist, and they end up with a degree in dental therapy. And for example, they can do extractions, simple extractions. Then we move on to the oral hygienist. For many years, this used to be a diploma in oral hygiene, but more recently, it's moved into a 3-year degree in oral hygiene that oral hygienists now come out with. And essentially, they do things like scaling and polishing and education and prevention. And the other person intimately involved with this oral health team is a dental assistant who then assists all three of the dentist, dental therapist, and oral hygiene as part of the team. We then have a dental technician who plays a supportive role with some of the restorative work, mainly with the prosthesis, with dentures, with those kinds of things. The dental technician plays a role there. With the making and assisting with that part of dental treatment. So that's essentially our grouping in South Africa.
All right. That's interesting. Sorry, go ahead, Marie-Claire.
Thank you so much, Professor Shabir. I think my question to all the panelists is with regards to training of health sciences cadres on oral health. Just to give a small context, I think when I was in final year medical school, we were the first class that were told to go through a dentistry unit, and it was taken by a majority of us with a lot of resistance because we could not understand why we were being taught oral health. And this is just a unit, I think, that was only being offered in our university in final year. That's University of Nairobi. And that, I think, begs to bring out the gaps in training of other health cadres on basic oral health components. So I was just curious how the situation is in South Africa, and probably now in Dr. Anbar's case, probably what measures are being put in place to ensure that also other health cadres are a bit empowered in matters to do with oral health management. We could start off with probably Dr. Anbar.
Thank you so much, Dr. Marie-Claire, for that question. So, as you rightly said, it's very important for integration at training level. And I'm surprised to hear that you were the first batch to go through dental training. Is that true, Dr. Marie-Claire? Yeah?
Like in final year, as a unit in final year.
Final year. All right, okay, because in the past, like doctors, medical trained doctors used to go through training for oral health, dealing with emergencies. So that's as of now, I can't say that it is being done in all universities in Kenya, but it's a good point that you've raised, that we should ensure that it is being done, because doctors work in settings where we don't have dentists sometimes, most of the times. So it's very important for a medical doctor to know how to deal with dental emergencies. And yeah, it used to happen in the past. I just don't know what happened in between. I trained in India, and all medical students in India used to come for dental attachment for 3 months. Yeah. So yeah, it should be done.
Sounds useful.
I'm very impressed to hear this because as far as I know, we certainly do not have anything like this in our medical setting, where our medical trainees spend time in a dental facility. What I do know, and we have tried to encourage, is that at least part of their training curriculum in theory has some input about the importance of oral health in general health, and specifically related to the oral manifestations of HIV, for example. That was something that came to the fore, but oral manifestations of disease in general, that's something I know some of the medical schools have included in their curriculum. But as for any time spent in dental settings, I don't think that happens with our medical trainees. I don't know, Shabir, you might be able to assist with that, but as far as I know, we have never
none.
We have never had
Absolutely
medical students in dental settings and dental facilities. And it would be really useful if they could spend time in some of our public sector dental clinics.
Yeah, very much. I agree. If I may ask, just there are a lot of, there are people in the meeting here. I'm curious to see if there are any dentists or dental oral health professionals of any sort in the meeting. If you don't mind, raising your hand or unmuting yourself and sharing a little bit of your insight about dental care in primary care in your setting. Is there anyone with that? Is everyone a medical or other professional? Anybody from the oral health professions across Africa?
I've just seen in the chat that 2 of our dental public health registrars have just apologized and left the meeting. But I don't know if there are any other dental I cannot recognize. Yes.
Yeah, I think if we have other sort of settings and the experience, if any of you are, I think it'd be really useful to share some of your insights in your country. I know, we've got a footprint across many countries, and maybe even some of the people, and I think if we can just engage them, James, I think even Robert, do you mind sharing a little bit? Robert, I know you're from South Africa, but you're from Nigeria. Do you want to share a little bit about anything in that part of the world?
Good afternoon, everyone.
Yes.
Hi.
Can you hear me?
Yes. And Robert, if you don't mind, just introduce yourself
I've been enjoying the discussion so much, I got carried away.
But just introduce yourself very briefly so that people know.
I'm Dr. Robert Oyedipe. I'm a retired chief dentist from the district of Tshwane in Gauteng, South Africa.
Nice. Do tell us, obviously you're familiar with the South African, we've got a sense of South Africa, but I'm sure, in Nigeria, you have a sense of how oral health fits into primary care. Do you have anything to share?
Yeah. I think the first 2 years of our training, the medical and the dentist teams, students were grouped together to do the basic sciences, which is your physiology, anatomy, biochemistry, and so on. And then on the third year, you are separated to start your dental studies, while the medical team continues with their medical studies. But third year and fourth year for the dentist, you are supposed to do some, take some courses in medicine and surgery.
Right.
And the fifth year, basically you are on your own in dentistry. Okay. So that's the scenario. Medical students are not, medical students are not given the opportunity to come into dentistry.
Right. In other words, to even come and experience dentistry, not so much to study it.
There's no such opportunity. Okay. The workload is so much.
I know.
For the medical teams. Yeah.
So what about primary,
particularly in the fourth year, where they are supposed to be starting their pediatrics and community medicine.
Yeah. Do you find in Nigeria the primary health care, is oral health part of it? Or is it just, what's the situation in Nigeria?
I think the situation like Dr. Ganatra presented is similar to most African countries. Right. There's very little integration between the oral health and primary health care. It's always been a silo effect.
Of course. Yeah. And I think Matthew also wants to share. Matthew, go ahead. Thanks, Robert.
My name is Matthew Oladile. I'm a public health practitioner, professional in Nigeria. This workshop is very exciting and something very good.
What's your background professionally? You said public health, but professionally?
Yes.
Dentist or doctor?
No, not doctor. Public health. Hello?
Yes. Just want to find out your professional background.
Public health policy profession. We support.
Policy. Okay, yes, so PhD, not a problem.
And health governance. So we in Nigeria, the primary health care does not have any indicator or services that has to do with the dental care. Even common dental hygiene, I think it's kind of silence in all the services being provided at the primary health care. Even if you in public health service, even if you look at the health insurance coverage, the packages does not include dental services. So with all the recommendations that this should include in the packages of general health services at the primary health care, I think it will go a long way to solve a lot of issues, because when you look at some of the adverse effects of poor dental and oral hygiene, you will see that there is a lot to do. There's a lot to do, and when your mouth cavity is not healthy, it can contribute a lot to your health system, which can even the doctor said, the presenter said, can even result to death. So I think this is something that should be taken further to see that it receives the attention that it's needed. Over.
Wonderful. Okay, good. Thank you very much. Appreciate that, Matthew. I know Ibrahim Sano, you're from Liberia. Do you want to share a little bit of your, is it very similar to what's been presented, Ibrahim? Ibrahim, just share a little bit about yourself as well.
Okay, I'm Ibrahim Sano by name and family doctor. I practice in rural Liberia, Maryland County. I'm the medical director of the hospital here. Our situation in Liberia is no different from what many have said. Doing my undergraduate program in a medical school.
So I think Ibrahim's struggling with sound.
I did not come across anything dentistry and training in dentistry throughout my medical school undergraduate program. And even when I did my postgraduate, because we are family physician, we had an opportunity to do 3 weeks rotation in oral health.
Right.
Apart from that,
that's nice.
It was,
Yeah. So in terms of practice of primary health care, I mean, in the public health, primary health care space, is oral health just ignored? Is there anything happening in that space in practice? Or do you as a family physician tend to cover, do lots of things?
Yeah, as I said, the hospital I'm a director of, we receive a lot of oral health cases, and most of them come as a complication. Right. The complications are addressed mainly by the general surgeon we have here.
Right, abscesses and that kind of thing.
Yeah, IND, you know, they drain the abscesses. Okay. But the root cause, the main root cause, which may be due to caries or whatever, is not addressed.
We don't have any dentist in the hospital.
No, we don't have any dentist.
And any dental professional at all.
At all, we don't have.
Okay, very understandable. So I'm sure your 3 weeks is coming in handy. Well, that's great. Thank you for that, Ibrahim. I really appreciate that. I think Susan's got something to share. Susan, go ahead, unmute yourself and proceed. Let me just help you to unmute. Go ahead. And then Robert, I think, has something as well. So, sorry, Susan?
Yes.
There you are.
Thank you for the opportunity.
Yes, go ahead.
Can you get me? Can you hear me?
Yes, we can hear you. We can hear you. Great.
Hello?
Yes, we can hear you. We can hear you. Can you hear us, right. Susan?
Yeah. Yes, I'm Susan. All right. Okay, I'm Susan. I'm a nurse.
Susan's connection's a little challenged. Robert, go ahead while we wait for Susan. And others who would like to contribute from your country, just your little bit of experience, you know, even though you're not an oral health practitioner, if you could just share a little bit of, you know, what you see and what you feel. Robert, go ahead. Shall I help you unmute?
All right.
Go ahead.
Thanks, everyone. I just want to add to what the expanded scope for oral hygienists is now in South Africa. They are actually able to do what is called the limited extractions, mainly for children, and they are able also to, they are registered with the HPCSA to do what is called, to give local anesthetics to children and do some form of extractions. Right. That's just what I wanted to add.
No, true. So that's dental therapist.
The oral hygienist. The oral hygienist.
So they've been expanded. Scope has been expanded.
Yes, they've been expanded. There's an expanded scope. Right now for the oral hygienist in South Africa.
I'll come in just now. I want to actually share some insights into work done in South Africa around the national health insurance for primary health care, some of the models and thinking around it, and in fact, some of the challenges when it came to discussing, oral health, and what are the sort of issues that need to be dealt with by the different professions to fit in better into primary healthcare plans. Hopefully that the government actually does embrace. So thanks for that, Robert. I just want to, before we get there, I just want to make sure that we get much more voices into this conversation to share at least some of their insights in other parts of Africa. I think, Cynthia, you're a member of the board. It'd be really useful to see in your setting. I know, James, I think you're from Uganda. If you don't mind sharing a little bit of what you have in that setting. We've got Nkwan, Jacob from Cameroon. Would you mind just, raising your hand and we could just get to understand, and any of you as well. I know, Pratiosa, you are in, and Susan, if you are unable to join, I do know you can unmute yourself. Let me just give you that opportunity. You were talking and you fell off. So if you can unmute your area, if you can say your thing, I think hopefully it does work now. Go ahead. Yes, if you can speak without putting a video on so you don't interfere with your sound. Susan?
Okay.
Do you want to try? There we go.
Yes, thank you. Thank you, Prof.
Good.
Okay,
Good.
Thank you, Prof. All right. So I was just saying I'm coming from Cameroon. Wonderful. I'm a nurse. Yes, I'm a nurse. I am by profession and a nurse educator. And I say that we have dentists, specialists in our different hospitals, although they are limited in number. And actually, when you go to the rural areas, you rarely get these dentists. They are like more in the urban cities.
True.
And since we don't have a kind of a training school where they are being trained, it makes the number so limited. And like my university, what we do in training with nurses, we have just a small content, which is not very significant, just for them to understand the basis of oral hygiene. And so in the different hospitals, they actually do not practice this basic hygiene or practice oral hygiene per se. But I think people need this awareness, which is not done in my own context in Cameroon. It's not really done because people, you hardly see people actually going to the hospital that they want to go and consult because of oral hygiene, understand? And because of that, it makes it difficult. People believe that it is not really a major issue. But when you go to like a unit like the ophthalmologist, that is the eye, you want to see more patients using that unit rather than using the dentistry like in other units. So it makes it very difficult. I think it's something which like the presenter said, is when you look at how vast and how people are so used to dentistry or oral hygiene, it is well developed in developed countries than in developing countries, and Cameroon not being left out. I think it's something we have to actually try to incorporate it in our primary healthcare, so that individuals will be able to actually enjoy that facilities and create awareness, especially when it comes to rural area, because the rural area is where primary healthcare is supposed to be well established, which is not the case in Cameroon. So that is the few things I can do.
Yeah, no, thank you. That was very useful. Perhaps you, and then Jacob is also from Cameroon. He can share a little bit. Do you all have mid-level, like was mentioned by Prof about, dental therapists, oral hygienists, etc. These other cadres where you only, you don't only have a dentist, you have others. And then the other question is, the current dentist in the hospital that you say is there, is he just doing curative work, mostly extractions? And do they actually try to do anything in terms of reaching out to primary care facilities or doing prevention in any way? Maybe you can offer some thoughts, and then maybe David or Jacob can also answer that as well. Okay. Any thoughts? Yeah.
Yeah. What's actually the dentists who are at the level of the hospital, what they do is extraction, a lot of extraction. And I think a little bit of preventive, preventive, as I can say, because we have caries, which they can take care of, because I was able to be a victim of caries, and I had to. Yes, I had to go to the hospital where actually they did not help the situation, because my tooth was filled, and the preventive measures were not taken into consideration, and somehow therapeutic too. So I am still living with that situation or that condition, which has not been handled, because time and again, it keeps repeating itself. So there's a lot of limitations when it comes to preventive medicines with oral hygiene at the level of the hospital in Cameroon, which I can testify because I have been able to use that unit.
Yeah, absolutely. Thanks, Susan. Appreciate that. Thanks to you, Jacob. Perhaps you can share a little bit of your insights, and go ahead. You had your hand up, so you can say anything you wish.
Yeah, Prof, good afternoon. Okay. Good afternoon, everyone.
Yes, it's good. We can hear you nicely.
Thank you.
Thanks, Jacob.
I agree with Susan. I'm a nurse, and I'm working with the Cameroon Baptist Convention Health Services. The dental services in Cameroon are still very not well organized. The dentists are found mostly in urban settings, and
mostly private.
Yes, my organization is private.
Okay.
And I was saying that the dentists are found mostly in urban facilities. and some of them work in government hospitals. Then, but many of them, they work in private clinics. Right. And Susan mentioned about extractions. Generally speaking, the extractions are done mostly in the community, not in the hospital, and usually by people who are not actually trained practitioners. And so all the specialized is extraction. I've never had the opportunity to visit such a facility, so I really cannot say what happens there. But I know that they do it as a way of raising income, and sometimes they extract teeth that are not actually supposed to be extracted. And then the dentists generally, they do restorative treatment, they do prosthodontics, periodontics, and so on and so forth. And so now, the general situation of dental or oral problems in Cameroon, I am taking, considering the data that I have been collecting from here in my school since 2012 up to date. We have been screening every student on admission for dental problems, and we discovered that close to 80% of them have dental problems. And the majority of them, they have caries. Then a few of them, they have plaque. And then some of them, I mean, in fact, if we were to really consider in terms of importance, I think that oral care and dental hygiene or dental care should be one of the very, very biggest components of primary healthcare. Considering that, now if you consider my data that I have here, because students who are entering the school, they are from the community. And if that data reflects the situation in the community, therefore, we will now consider that close to 70 or 80% of the population in the community have oral problems or dental problems that really needs to be corrected. And they will prevent, if you correct the problems in time, then it will prevent extractions or caries. Absolutely. And I think it's something we need to consider very, very serious. And then when the problem develops to a bigger problem, you know, dental care is a little bit expensive. And given the poverty level in our region, very few people can be able to afford, for example, a denture and so on and so forth. So it is one of the most important components of primary health care that has been neglected for a very long time. Thank you.
Well, thanks, Jacob. I think that's very useful. I'm going to hand over in a moment to MC, but I just want to say a few things before MC takes over. You know, we did some work which I think has been shared in a paper with the Lancet that I think I shared a little bit of it. It's on the website, my website, and there's a link on that article. But essentially in South Africa with the National Health Insurance, there was an exploration of primary health care models of care. And I was asked to do some work around it to help design, together with an actuary, a potential model of contracting. Given what is happening across Africa, increasing the UHC, where governments are saying, let's have UHC, let's get a single fund that will try to pool funding and get to change the model of current line item budget, which works in the public service, and also include the private sector, which is driven by fee-for-service, by creating a pool of funding that will then contract with providers, public and private, in the community, and then be able to find a way in which the funding can be, the strategic purchasing can work well. Of course, in the setting, most of the time, we are looking in primary care at a per capita payment system, which is a capitation system, which is very suited to primary health care, because it involves a lot of things that are beyond just a service, a curative service. And so it is much better, the system. And when we looked at this approach, within the sort of setting of a general practitioner, which was the task at the time, we said, we need to look at the models in Africa, in South Africa. And the model is pretty doable, where we can say, as a doctor, and we can look at the doctor in the private sector getting a team around them. And we've also got the public service where there's a team, but no doctor. And that too, because of the fact that in South Africa, as in all parts of Africa, people say, you know, I'm not going to work in the public service. I go into private. And in the public, I'm going to stick to the cities because I'm a professional. I can't sacrifice my life. They want to hang on. That's where we struggle. So in terms of trying to address this, we said, let's try and model teams, primary healthcare teams, and the way in which they could be structured for the country, and that the driver becomes the financing system, which government was saying, how do we structure this? So we said, well, let's take the resources in the country, and this is for doctors, nurses, and clinical associates, etc. And we said, let's create a sort of typical practice that could be the way in which we conceive of the contracting model. And that was saying, let's have one doctor as a clinically accountable doctor. We have potentially up to 5 nurses, 2 clinical officers. We were just trying to figure a model, and that model was just a minimum. This would be the minimum. It may require more, and we wanted 10 community health workers for a hypothesized 10,000 people. And that was based on the numbers available in South Africa. And of course, the clinical associate could be a clinical associate stroke primary health care nurse. Now, that was the notion of this is, that team could conceivably, based on expert consensus, could conceivably deliver care to a primary care, to a empaneled population. And to us, that's one of the big problems that we have, in Africa, is that we have got people looking after nebulous populations, but when it comes to this new contracting system that many governments are looking at doing, it needs to be empaneled populations, that the team looks after a specific panel of people. At the moment, these are clumsy, they're large, and they're not actually strongly patient or population based, so small population based. And we need to realize that conversation, we need to come forward as primary care practitioners and say, listen, we can model a population to PHC team that will deliver reasonably good care. Of course, we have to actually do research. Now, there's a lot of work being done in Africa that shows that task sharing in the medical model, or so to say, or the medical sort of space with a doctor, primary health care nurse, clinical officer, clinical associate, and community health workers in that mix can achieve some really strong, good quality, low cost, and good patient satisfaction, and the kind of model of primary health care that is very community-based with strong prevention promotion. Now, the work I do in Shawelo is an example of that. That was why I was asked by National Treasury to do this work, and so we incorporated it into the contract. And this is one of the things that struck me. And when we were debating this question, and of course, in that particular model, in the medical space, in that model, the price point turned out to be very much doable in the African context, in the South African context, with the number of doctors we have, nurses, etc. And in fact, very close to the private sector price point. So the public service spend in primary health care is quite high, and the spend in private medical aid spend on private is actually relatively low, and they're quite close to each other, which is an odd situation. It doesn't work all over. But when we looked at the question of oral health in that equation, and we took an example, we took the data from a medical scheme, which was the only medical scheme which was providing capitated care in South Africa, and we looked at the cost of oral health, it was almost the same as the entire medical spend. And what we realized is that for our South African government, which is spending, just managing to do this bit on medical health, where their actual oral health spend is relatively small, less than 5 or 10%. For them to deliver what is the private spend, even in the capitated model, it's very curative, I imagine. To do that would mean they would have to double the primary health care budget. And in South Africa, the primary health care budget is gigantic. It's almost half of the total health spend. So it's a complete not doable. And in fact, it raised the question is how on earth are we going to get primary health care, oral health care in primary health care happening? And the only way it could happen, which is happening in parts, I think, in what has been shared by Prof. Naidu, is that it needs a different model than the curative care. And we need to actually challenge people like the oral health professionals in this space to say, you need to be able to think of how do you actually configure a dentist with the other cadres in a manner that forms a team that could work with oral health practitioners, let's say in this kind of setting, who are capitated to a population which includes community health workers, where they could extend the reach of the oral health practitioners. But in that kind of space, be able to say, well, you know, in our setting in South Africa, we would need 1 dentist to 30,000 population and 4, you know, oral hygienists, or however the mix is going to be able to deliver the care to that other practices that are sitting out there at 1 to 10,000 each, and that we could deliver that care. That, again, care and then a costing that says this can be delivered at an X price point based on some simple models that we tested out. So I just want to share that thought with the oral health practitioner, because that same challenge exists for other disciplines, that it is going to have to be teams to population and figuring out the mix of team to a size of population and getting that in a way that could be thought through in models and then costed out and shown to add value in the mix that is available, that could answer the question that people at treasury level and Department of Health level would need. And certainly in the AfroPHC position paper framework, policy framework, we are advocating that idea very strongly, starting with basic primary health care. But the other layers, as we've said in there, will have to come in with the same kind of thinking. And I think, well, from what Prof. Naidu has said, that's the kind of thinking I think oral health needs to have. How do you create a different way of delivering care in our very resource constrained circumstances? So let me leave that as a thought. I'm not sure if the 3 panelists could start with replying to that, and then perhaps others could chime in on that. I'll leave you to continue the facilitating, Marie-Claire.
Thank you, Professor Shabir. I mean, that's quite something for us to reflect on. Maybe we could start with Dr. Magan on what she thinks on what you've just shared before I read some of the insights that have also been shared on the chat. And then we could go to Dr. Anba and then finally Professor Naidu.
Professor Shabir, I think you've given us a lot to think about. And I don't know that I have enough knowledge to comment with being a private practitioner, but I certainly feel that I speak for myself, that you know, some kind of partnership with the public sector, I am more than open to consider. As I said, I can't speak for my other colleagues from that perspective. But yeah, so I think that would be my thought, and I'm afraid I can't comment much more on that. I'll leave it to Prof. Naidu and Dr. Kantara. Sorry, thank you.
Dr. Anba?
Dr. Marie-Claire, thank you. Professor Shabir Musa, that was a very great insight on primary health care. With regards to the public-private partnership, I've seen it working in terms of the curative side, and most recently we've been having a lot of partnerships with public dental clinics being funded by private companies. So yeah, that I have seen work. However, in terms of the primary health care and private partnerships, probably when it comes to donor funded programs, that's where we could tap in. That would be my input on that. Yeah.
If I may respond quickly, Dr. Ganatra, I think it would be very useful in those, let's say, donor-funded projects to explore the question of very strongly integrated care. And do have a look at the website, my website, profmusa.com. The details of Shewelo community practice are there. And in a way, we can talk about it, because the possibility of having small projects is really useful to explore, questions like how the mix produces a result and what's the cost, and whether you can vary some of that. So I would strongly advise, because often these things tend to be narrowly focused on curative care, more to sort of relieve the public service than explore new models of care by the public service itself. So just a thought.
True. I'll definitely look into.
Great. Be in touch, because I think
I will. Yes.
Yeah, because
I have a lot of things that we need to talk about, especially after today's workshop as well. Yeah. Thanks.
Good. And I think do contribute to the document. It's still in flesh. We want to add oral health into it as a paragraph, and we have talked about it briefly, but I think we want to add more into it. So I hope you guys can help us to flesh that up some. Thanks. Prof. Naidu, your thoughts. Thanks, Anba. And anyone in the group, please feel free to engage with that policy framework. So, Prof. Naidu, yes.
Yeah, thank you very much for all that. Definitely food for thought, but few questions as well to you.
Yes.
Specifically with regard to how, I'm not sure if the model you use to try and estimate a budget for the incorporation of oral health into the package. We're working it out from a medical aid kind of using that as a basis. I'm not sure how practical that might be in relation to the kind of things we might see at a primary healthcare level.
Absolutely.
So obviously, as somebody might have heard, I think it was Dr. Megan's presentation, where she mentioned that 15 to 16% of the population have access to medical aid in South Africa, and the kinds of dental services that are offered at that level are at the extreme high top end of the market.
Yes.
So we have in the primary oral healthcare setting, out of the WHO, for example, for many years have been trying to push something called the basic oral health package, which is sort of the bare minimum of care, particularly that can be offered in a primary healthcare setting. And so I think when it comes to the kinds of things one might be able to offer at that level, it might be difficult to compare it to the kinds of serious first world treatment options that one can get in dentistry as a whole. So, and for example, there are basic, simple things that very, very recently we have added into the WHO essentials medicines list is something called silver diamine fluoride. And this material, it can actually be used to, you can do it, Prof.
A community of worker could do it.
You paint it onto a carrier's tooth. And so that brings me on to the second point, firstly, with regards to that treatment and the basic kind of packages one can offer at a primary care setting. But importantly, with regards to the cadre of person we need to deliver the kind of oral health services we need at a primary healthcare level, does not have to be that degreed dental therapist, the degreed 3-year degreed oral hygienist. We do not need that level of worker even in that primary healthcare setting. We can train non-dental people to offer the basic oral health package, including things like silver diamine fluoride. And another treatment that we've been talking about for 20 or 30 years, but it's just not sexy enough amongst the dental profession to want to take on board, is something called the traumatic restorative treatment, which again doesn't need a serious dental chair setup. To actually provide. You can do it in a chair. You can use hand instruments to clean out that caries tooth, and then fill it up or paint it up with silver dye fluoride. So I think the kind of package one needs to offer at a primary care level, we need to really put a budget to that now, looking at it with different options, and not an option of serious treatment. Those cases where patients walk in that require serious treatment, that is whom we need to refer for services. And the other absolutely critical thing that we are desperately need at a primary healthcare level is education about oral health, about how, and all those things that we spoke about earlier, about the risk factors. People cannot get their head around how the mouth is so affected by all those risk factors that cause obesity, diabetes, lung cancer, etc., that it equally affects the mouth. So they critically, that population that comes to the primary healthcare settings, those mothers, those young children need oral health education more than anything else, apart from the treatment that we can offer at that primary healthcare level.
Thank you. In fact, I think you are speaking to this exact same issues, that I think I'm concerned about. Now, I think the point I made was when National Treasury, we just found that data coming from the private sector. Yes. The trouble is that in the public service, there is no clear data as to how oral healthcare services cost government per population in a way that's extrapolating. And that's the problem that was held at the time. Of course, it wasn't the primary focus of that engagement, but it just brought up an issue. Now, I think the point you raise, and I think this is one of the cautions when we, in AfroPHC, we have been having a discussion about the fact that we really have a situation where packages are developed, and these are long time in medical field. There are even nice little cadres that do things, and then they said and lots of nice training, but what it translates to on the ground is policymakers saying, we've got this super solution by Prof. Naidu, let's roll it out. We don't need the dentist. We just train these people. We give them this training. We give them these few materials. And hell, you know what? We're going to solve all the problems. And we've said, doesn't work because this is not primary healthcare teamwork. And you need all the professions to be part of a mix. Because soon enough, that quality of training, that quality of service starts declining. And there is a need for it to be integrated with higher levels of care. So we strongly urge that kind of teamwork with that's exactly what you've said of having clear definable. One of the big challenges is how do we, increasingly the question of care to a particular defined population, not patients, population, is really the key denominator that we need to think of, because the global push is towards mixed capitation, and it's going to gather weight, and it's across the world, and we need to be moving in that direction in Africa to say, how can we conceive of it? Now, there's some work and some evidence, in other words, costed evidence of the cost potentially of that kind of team mix to a population. And it's there reasonably within the medical space with, and exactly to include community health workers. Why should I, and I do that in Shawelo, why should I be wasting my time telling people about smoking at length when in fact I don't speak the language, I probably don't talk to them in the way they should be spoken to, when I should refer the community health worker to do it? Why on earth should I be doing a urine test, telling a hypertensive, come back in 6 months for a urine test, when I can get a junior nurse to go visit the person in their home, do a blood pressure check, and check that urine? This is the kind of task shifting, and that kind of approach is already fairly settled because of the long experience in task shifting. Now, this is not evident all over Africa, and in South Africa too, it's not quite easy. And the question will be, and I'm wondering whether you have an answer to that, is there a model somewhere in South Africa at least, where there's a dentist and the different cadres providing care to a defined population, at least 10,000, that they can say, this is what we get as outcome, or bigger population that they know we have these people registered, we do everything, not just patient care, we prevent and we know, and that is not so easily available. And I think that's the kind of work that we need to do. And I wonder whether that's something we can explore if that's not happening.
Yeah, absolutely. That would be great to be able to set up something like that as a pilot study.
Yes.
And what we do have a lot of examples of is where mainly really oral hygienists have provided some kind of care in a medical healthcare setting. And we've got, for example, a grouping here, you may have heard of it, Pilani in the Western Cape, which was very heavily involved with mother-to-child business. And they then, with view to, I think, a generous support and donation from Sweden, they were able to incorporate an entire oral health setting into their Pilani exercise with the maternal care, with nutrition, etc., etc. But I recently contacted them only to hear that quite a lot of that impetus, like you said, has fallen apart and fallen away, and unfortunately even the kind of support they had from Sweden has fallen away. So just quickly before I lose that thread, related intimately to what you are describing, we need to ensure that those people you are talking about that you want on the team, particularly if you want an entire team of sort of highly qualified people, specialists, assistants, etc., we need to ensure they are adequately remunerated. In the settings you are describing, where they are providing professional care to the population. And I think this is where the government falls short. And this is precisely what you said very earlier on, that they rather be in private practice than to be in this kind of setting. So we need to critically think of, we need to remunerate them on par with what the private sector receives, to be able to keep them in that kind of setting that you just described, serving population health. But I know I might have spoken rather rapidly with my 20-25 minutes that I had to do my presentation. But what has come out strongly from the successful cases, whether it was Australia or the US, interestingly, was a terrific public-private joint enterprise that fit into what you described about population services. So where we had a community of, say, 35,000 people, and then we fit in the model that you spoke about, there was a fairly strong input from the private sector, financially and human resource-wise, that made those models successful. Yes. And that's still what we don't have in South Africa, unfortunately, where the private sector is still very far removed from grassroots primary healthcare settings.
Yeah.
So they
well, it's not
yeah, we've got some small examples, but they are not to the extent that you described, population group wise.
Yeah, and I think that is a part of the problem of the framework of funding. Our government and the medical schemes do not go this direction, and they're just reluctant. They don't have the vision. Government is thinking through this sort of approach, but again, it's struggling. To me, I give you an example, and I think it would be something that will help you to see how the remuneration can be material. An example is that at the moment, the average GP is in South Africa. And I'm using a medical example because I've done work in that space. An average GP, and this was a while back, was seeing 22 patients a day at about 267 Rand. That's about 10 years ago. It's about double now, but quite happy with the income. We then did a bit of work and looked at, in that time, if they took on a capitated model of care, they came up with an amount of 36 Rand per person per month, which is hugely distant from their 260 Rand fee for service. So this just gives you some sense of how differently they think of when they were put forward with an idea of, now you want to take on a panel of people who will then belong to your practice, and you'll get fixed payment per month on the basis of them. And a key question became, well, actually, what is the need that I have to address? Because I'm getting prepaid now, and I have to provide that care. I have to understand what levels of care and how much of that care different cadres will be needed. So it's an example of the difficulties. And of course, the big question became the utilization rate, because in the mind of the GP, they saw visits to themselves as the big problem. And of course, they expected people to abuse it, etc. So based on that, we did have some of this discussion in the Treasury, this discussion of a model. And in fact, it was assumed that if we looked at the key care model in the private sector, that would be a good measure of the utilization rate in the private sector that might be applicable to this NHI model. And so their visit rate, which was 4 and not 6, which is what most GPs thought it was, we said, well, that's a ballpark that the National Treasury thought, well, that's a measure by which we can premise our current modeling. And in doing that, it was landing up that the money being spent would be about an estimate, and I'm really speaking with estimates because it was a confidential discussion, but this is a public sort of knowledge statement, that the government at the moment is spending about 1,000 Rand per person per year in South Africa on primary health care. And assuming, the other bits taken out, which is about 10 or 15%. That's allied health and other things like dental health, etc. When they looked at that amount, that would mean that any GP who contracted for the NHI would have been paid 1,000 Rand for consultations only, and that was in that model. And 1,000 Rand would land up that he would get 10 million as a number. And that's 10 million Rand. So for those who are outside South Africa, I'm giving you a situation in South Africa. In that 10 million Rand, the estimated use of visits based on the key care model would be 4 visits, which would be 160 persons per day. Now, obviously, the GP would be able to say, well, I'd have to sit and employ with 10 million. I'd have to employ, do I employ another doctor? Or do I employ a primary health care nurse, 1 or 2, a clinical officer, a couple of other nurses? Because I have to think through that mix of services I would need to provide to that estimated 160 people, thinking that that's all consultation for acute and chronic care. So that's the mix, and it's fairly simple. I mean, they could be, that's the kind of thinking that went through. And of course, in a way, it's a doable project. The key problem is if the utilization gets higher, but the likelihood is it may get lower. So that was just some thinking around the possibilities. Of course, when we shared it with GPs, they were quite happy with the model. I actually took that premise of costing and looked at what I did in Shewelo, which was now not just the very curative-ended model. In other words, GP sitting there and saying, oh, I'm going to get patients coming in, let me equip for everybody to come in. we said, no, wait, let's think this through differently. Let's not wait for patients to come in. We register a population of 10,000 in Soweto. We're going to proactively prevent. And our proactive prevention was premised on 4 things. One was, let's get community health workers who are going to register the person into the practice, but they will then be telling the person, I'm going to get some information on you, and I will understand better your circumstances, screening for disease, etc. And I will link you to the practice. The second thing is that at the practice, we had a very strong record-keeping system and a management system that linked the community health worker to the practice. So there'd be a constant repeat sort of repetition of the link that the community and the value the community health worker played in our teamwork. So we would constantly refer to the community health worker in the conversations and refer to them in the community, etc. And of course, the practice was pretty standard practice that was community-oriented, yes, but very family-centered and just simple good practice, and doing all the stuff that happens in practice, except for that difference of linking the community health worker. The 2 other things we did were we got from that community of 10,000 representatives to meet with us regularly, and we reached out to all sorts of stakeholders, met with them, and tried to say, work with us so that we can do some work in the community with these community health workers and be proactive. The 4th thing we did is we tried to gather information from these 3 different quarters, information we were getting from the clinic space, the community space, and the stakeholder space. And we then said, let's do targeted health promotion with the community health workers and with the stakeholders. And that's all we did. And it wasn't very effective. But amazing thing happened. Our utilization rate never climbed above half a visit per person per year. So where the private sector expected to see, and the model was 4 visits per person per year, we found ourselves not getting above half. And we were worried. We said, are people not aware of this? Why are they not coming? We're free. We've got doctors here. We've got a good team of people. It's this good private care. People didn't come. We asked why. No, we're happy. We then went into the community. We realized that 97% of the community that we had targeted actually saw us as their primary care use. They were using us on a correlated visit to need level. So in other words, where they felt need, they used us. So we satisfied their felt needs. And then we asked them the question, how did you feel the community health worker altered the visit? Did it increase it, which is what the public service tend to think they do, or decrease it? 44% of our residents said community health worker decreases it. But it's not just what the public service is doing right now, which is poorly linked community health workers. We have a very different situation. And the patients and the community health workers say, we're different. It's not happening in the rest of the country and in other parts of the public service in South Africa. We have very strong linkages, and it makes a big difference. We drove our utilization route potentially down to 1/8. And that makes a huge difference to the potential. So for example, if we were to set up models with doctors, and this, of course, a private doctor could potentially enter into this contract and get 10 million Rand, but he actually can just see 20 patients in this model where it's a strong community orientation. He just knows how to get community health workers as part of his mix and try to focus on the elements of community orientation in his approach, which is a lot of what we've talked about, prevention, etc. And he would be able to drop utilization and make a whole lot more money in private sector. And if that could happen for a GP, I can't imagine that the same kind of thinking couldn't be thought through in dentistry. It may not be 10,000, it may be 50,000. Because the volume of work from a population is not necessarily the same as the medical burden. The oral health burden may be a lot less, and maybe even less if there's strong community orientation. So these are the key questions I would say, you'd need to think about, and that even Dr. Magan in private sector may be very keen on entering a contract with the government to provide oral health services where she's working with a set of 5 or 10 community practices, with each having a GP and their set of community health workers. And she may be able to provide that service, work in collaboration with them at a very low cost, and may be able to deliver exactly as you said, Prof. Naidu, could happen with a lot more of this thought. The key question, of course, is how many patients is the model, how many people can the model take on, and what's the mix in that model? What's the best mix? 50,000 to one dentist or 100,000 to one dentist, and what about the other mix? So that's a key question. I hope it's a little clearer as to the question you raise of the remuneration. You can fit it to suit the need, and I should think it can be very lucrative for those who do enter this model.
No, thank you very much for that, that clarity. It brings a lot into perspective now. And I think if one needs to, in inverted commas, sell it to potential practitioners, that's the kind of examples we would need to give them so they can understand and appreciate where it's all coming from. We do have examples of this in other parts of the world in dentistry, but very, very specific treatment modalities. So we use the term capitation. I guess that's, in a way, you didn't mention it, but that's what they called it, capitation, where you enroll people into your practice. And for example, dentists, I think it was in the UK, were given a capitation fee for enrolling youngsters, children into their practices, and a similar kind of scenario to what you described, but to see them, say, at the start of their permanent dentition and to only offer things like fissure sealants, which seal up the grooves in the molar teeth to prevent it from decaying, or to offer a fluoride varnish treatment annually or something like that. But one of the disadvantages they found with the capitation system was what they called supervised neglect as part of that whole scenario of capitation, where they got, and I'm sure you've seen that as well, where they had people, they were getting paid for per patient, but the patients were not actually coming in. So there's all sorts of scenarios, but I'm sure one can develop something unique. And that's also how I started off with some of my case studies, that while they were coming out of seriously industrialized and developed countries, we need to take their wins and gains and learn from them to extrapolate it to fit our African situations and scenarios. And we need to work with what we have, the personnel, the community health workers, the cadres we have. We need to be able to include them into that multi-model that you were talking about, to make it a success for Africa and the African scenario. Earlier on, I think it was Jacob who mentioned about pulling out teeth in the Cameroon. And of course, traditional healers play a terrific role with regards to oral health in many parts of Africa. And in fact, a student of mine from the Cameroon, from the northern Cameroon, a doctoral student of mine, we did an extensive study of the role of traditional healers and oral health in the Cameroon. So again, if we don't have, and we're waiting for these oral health professionals to be trained and educated, we also perhaps need to tap into other kinds of healers that populations and communities are used to working with.
Absolutely. Absolutely. I think traditional healers are part of that mix, perhaps even maybe peripherally in terms of structured, but certainly part of the stakeholder set that we need to engage with.
Stakeholder set, yes.
Yeah. No, thank you. I think let me just give Marie-Claire, she's unfortunately had to leave, but I'll manage the rest of the meeting and we'll just close up shortly. Marie-Claire, and then I'll just have some closing comments. I think we've had a really super panel and really wonderfully engaged audience. And I just give the three panelists a chance to sort of you could make a closing remark, but MC, because you're leaving, go ahead.
No problem. Thank you so much, Professor Shabir. I think this has been a pretty fantastic conversation on oral health. I think almost all of us are now more informed on our crucial role in primary health care regarding to oral health, and it's still being within the week of Health Worker Week. I think now the call to action is on us to have an all hands approach towards oral health. And I think it's probably time we rephrase the saying to now there's no health without oral health. So I think there's still more to be done, and there are fantastic insights that have been given verbally and also on the chat that probably some of you might not have had a look at, stories on Zimbabwe, Mozambique. So also do have a look at that. But mine is just to thank you all and to urge you all to keep on maintaining the conversation with us at AfroPHC, and to thank all our amazing panelists for the insights that they have shared. So thank you very much. And we can still continue the discussion on Twitter with our hashtags and tagging our account. Thanks.
Thank you. And I'll just let our speakers give a few moments before we finish at 4 o'clock, so at our time. So perhaps we could start with, and all of you have been really, our pioneers. So thank you for taking the time to be out here and sharing your thoughts. I'll start with Anbar, and then Ansuya, and then Sudeshni. So Dr. Ganatra, perhaps a closing remark, your thoughts about this whole experience and the way forward. Maybe Dr. Magan, you're unmuted, you can go ahead, and then Prof. Naidu, and then we'll come back to Dr. Ganatra. Go ahead. Just some closing remarks.
Thank you. I think today's been most insightful, and it's highlighted the complexity of addressing the integration of oral health into primary health care. And I think we need lots of further discussion on how we can work together to take this forward. So just lastly, thank you for the opportunity to be on today's panel.
Thank you for joining us. Yeah. Great to have you join us. And we hope to be in touch and take it forward, like you said. Thanks, Dr. Magan. Anbar, if you're available, otherwise Prof. Naidu. Go ahead, Prof. Naidu.
Yes, again, same to thank the entire group for participating, and importantly for inviting me to be part of this. It all was very sudden, but very, very exciting stuff. And it's frustrating for me because after, I don't know, I'm giving my age away with many, many years in the public health, dental public health arena, I still despair that we have such a long way to go to really truly see oral health being integrated into. We talk about it, but it still seems to be far away. But listening to you, Shabir, I think I can see it is not insurmountable, and certainly while we may have a long way to go, there are challenges now we can really address and start talking about at another level. So I'm always grateful for all my non-dental colleagues who are interested in giving an ear to listen to us about oral health and the importance of oral health. And it's a small start, but let's hope we're going to go a long way. And I'm looking forward to further collaboration, particularly with the last 10 minutes of your discussion, to see that we don't lose sight now of making sure that oral health does not disappear from the national agenda, and certainly to colleagues on this group internationally, that we can all learn from each other.
Absolutely. No, thank you, Prof. Naidu. I think I really appreciate your expertise, and I'm sure we're going to be in touch. And I particularly am hoping we can look at some sort of research projects collaboratively to unpack that in the discourse.
I think it's necessary.
Absolutely. And please do keep it up. I know it's very despairing sometimes, but just stick in there, just be in there. You're a pioneer, and many will remember your contributions. Don't worry. And we'll be in touch. So thank you for joining us, and we will be there. So Anbar, Dr. Ganatra, just a last comment, and then we can close. I'm not sure if Dr. Ganatra's have been occupied, but thank you all very much. I think it's been really great. There you are, Dr. Ganatra. Some closing remarks, and then we can just say thanks to everyone.
I'm very grateful for this platform, and I hope we can have more of these. And like, we need to bring oral health to the forefront. So I'm really happy and grateful for this platform. Thank you.
Great, thank you. And I want to, sort of urge everyone in this meeting, and this is not just the dentists, but everyone, to reach out to all our colleagues. We have all sorts of different disciplines in our midst and in our networks. Reach out to all of them and say, come join AfroPHC. We are talking about everything. And I mean, we need to have this conversation about every member of the team. Everyone is important. And I think that they're easy to miss some important elements. We want to make sure that we get to talk about all, because we're one primary health care team in Africa. And if we're to get good primary health care happening across Africa under universal health coverage, as AfroPHC is advocating for, we all need to be that team and reach out to everyone. So I want to urge you all, AfroPHC, just tell people to Google and join it. Lots of activities, lots of stuff happening, great place to be in, as you can see, and we hope to continue this discussion. There's the policy workshop, but there are a lot of other things as well. So the next policy workshop will be canceled or postponed because the next meeting is our conference in the same time. And at that time, our conference is going to be wholly about the policy draft, policy framework draft, which we have talked about, I've talked about briefly, and which is shared. So please do try to look at that document and be part of the process of our conference in about a month's time. So I'll be sending out emails, and thank you all for joining us. Take care, everyone. Be safe, be well, and thank you especially to all our panelists. Bye-bye, everyone.
Bye.
Bye.
Bye-bye.
Thank you. Thank you.
Thank you, Prof.
Bye-bye. Thank you, everyone.
Bye-bye.